Hi everyone, my name is Kim and Shakil and I are here from Runnymede Healthcare Centre today to share with you our journey in advancing health equity and how we leverage that data and how we've been using it to really enhance our patient experience. Now, having the opportunity to speak to some of you yesterday and today, we recognize that this is still a very new and evolving journey for many of us. And so we're eager to learn more from each other, exchanging insights throughout this whole process. Oh, sorry, I think there's a glitch on the screen. There we go. So just an overview on our case study today. We will be going through an overview of our Measuring Health Equity project. We'll be going through how we collect the data and managing that data. We'll be going through the use and application of that data, all of our data-driven improvements and how it impacts our patient experience, as well as our health equity plan going forward and our key areas of action for future. So just a quick little background on Runnymede Healthcare Centre. So if you haven't heard about us before, we're located on the west end of Toronto. We are located at Runnymede and Dundas West. So we are in the Parkdale High Park area. And we are a 206-bed hospital with 2 rehab units and 1 medically complex unit. So all 3 units serve to enhance our patients' functional abilities, improve their quality of life, and we strive and we aim to get them back to their home or in their community as soon as possible. And so, our session and case study is all about, leveraging health equity data. So just a refresher on what is that. So what is health equity? So according to Ontario Health, health equity allows people to reach their full potential and receive high quality care that is appropriate to them and their needs, no matter where they are, what they have, and who they are. So I always like to depict that little image at the bottom there, just to quickly summarize, equality does not mean equity. So as you can see with the equality, all 3 individuals are given the same tools and resources, in this case, the same level of the little box, assuming that everyone starts out at the same stage, right? However, you can see that some of those individuals are still, having barriers and challenges to reaching that apple. Equity, on the other hand, recognizes that each of these individuals may have different circumstances, may have different needs. So our goal here is to really provide them with the right tools and opportunities and resources to ensure that they reach an equal outcome. So really, health equity is about striving to provide the highest standard of health for all. So this is a framework that we use to collect our health equity data and to ensure that we are providing equitable health. So this is a framework that was provided to us by Ontario Health. It is evidence-based and data-driven, and it has various components in that framework. So just to go through each of those stages, and we'll go through more of the details of each stage throughout the presentation. So the first step is to collect. So collecting the patient-level demographic data is really the fundamental building block of this entire framework. Number 2 is identify and report. So once we have access to that data, we're looking at examining the differences. We're breaking down each variable to understand the population we are serving. So whether that's language, race, gender, income, we want to know who we are serving. Number 3 is improve care based on identified inequities and patient needs. So at this point in the process, we are aggregating, analyzing our data. This is a time to look at what tailored interventions or quality improvement initiative we want to roll out to meet perhaps our patient needs and population. And lastly, the last step is, as y'all know, is evaluation. So at this point, this is to do a comprehensive review of our entire process, looking at our data collection practices and our intervention programs that we have put in place. And we just want to note that, while we have, at Runnymede, made significant progress in the first 3 stages, we have not yet reached our evaluation stage. And so Shakil will talk more about that in the later slides in terms of what we want to do for future and our key areas for action. And beyond the data collection aspect, we understand that monitoring the data quality is important, or else we won't be able to utilize that data. So I'll just pass it along to Shakil to speak more about this section.
Thank you, Kim. So she decided what slides I should present. In reality, she is the boss. So thank you, Kim. It's all hard work. So two things. We are not data experts. We are not equity experts. But sometimes candle tries to share its light with multiple suns here. So that's what we are trying, and we are sharing our journey. But I also say that the macro system, the big organizations or provincial organization, sometimes or most of the time need to also see what's happening in the micro system or small hospitals, and maybe something that can be taken and expanded everywhere. And the small hospital also needs to learn from the bigger organizations, and that's why we are here. We are constantly learning. And so in terms of you guys already hinted about data, implicit bias. So we thought, the data should be very inclusive, right? Trying to address the diverse patient population. So when patient relation trains the volunteers, they urge that make sure that you are being inclusive in data collection. You don't want to go with your comfort zone and ask certain patient population and come with it, because then it's not inclusive. Also, involving the DAHC committee is also another way of ensuring that there's diversity. Since yesterday, we have been learning about governance, and but we are a small hospital, so sometimes it's very easy to get the governance done. So we said to the chiefs, hey chiefs, get together, and we are going to call it data governance. Our chief technology officer also sits on that, and every month we present to them our progress. And we are giving you hints in case you are not still under the scope of Ontario Health. So I know Toronto hospitals they are going to expand, and they are going to ask for Ontario Health Equity, your organization Health Equity Implementation Plan, maybe next year. And we have been involved in that, and that's why all this work is coming. This is a homegrown diagram, so nobody else can patent it. But it's about data sharing, so use it. Don't worry. We are ready to share. So in this, the message to anybody is that it's all about patients. Okay, we all are there inside trying to collect the data, understand the data, but it's about improving patient outcome. That is the main goal. Thank you, Kim.
Thank you, Shakil. So just building on what Shakil just said, we'll go into more detail on how this all started, right? So the Measuring Health Equity Project. So how this all came to us was back in November 2022. Ontario Health released 13 structured standardized questions called the Measuring Health Equity Project. And I just want to clarify that this is only currently being rolled out in the Toronto region. So I was speaking to others yesterday who were not in that region and didn't know, what this project was, but like Shakil said, it may be expanding, or you may have heard of it already. And so, in the next slide, we'll show you the questions, but these core adult patient demographic questions were updated to be more reflective of contemporary language, diverse experiences, and identities. So this is really just a snapshot of the 13 questions that we're currently asking all of our patients who are admitted to Runnymede Healthcare Centre, whether they're in the medically complex program or our rehab program. So like I said, these are pretty structured, and so whatever the question is, we are trained to ask verbatim, reword it the way that it is worded, and sometimes we will try to reframe the question so that the patient will understand, but for the most part, we were trained to pretty much read the question as it is. And just to give you some background, so each of these questions is either in the form of a checkbox style or a free text response. I believe only 2 of these questions is a free text response, but for the most part, all these questions is select all that apply or select one that best describes your identity. So as you can see, it ranges from language, Indigenous identity, to disability, to gender, sexual orientation, and income. So now we want to go into, once we got that mandate, how do we go about and collect all this data? So when Ontario Health reached out to us, we as a group and a big group of relevant stakeholders got together to look at, okay, how are we going to implement this project? How are we going to meet all these implementation plan deliverables? And so one of the top three areas that we were focusing on and discussing on was the structure and location of the questions, where is it going, how are we asking it, which department will be asking the questions, or is it something that patients will do on their own, maybe through a digital survey, questionnaire, maybe perhaps on their integrated bedside terminal. So these are things that we were discussing. And lastly, Ontario Health wanted all hospitals to build all these questions into our electronic medical record. So we'll go more into that in the next couple of slides, but that was something else as well that took some collaboration, because we use Meditech Expanse, so that is the same EMR as Humber River. So we were working closely with Humber River, who were going through the same process to work on building that into the EMR. So after much discussion, it was determined that patient relations and experienced staff, along with any volunteers that are assigned to our department, were tasked to support the asking of these questions in person at the patient's bedside. And so Ontario Health provided us with a very comprehensive training guide, videos, scripts, glossaries, to ensure that each staff and volunteer understands the terminology related to the questions, the purpose scope of the project, and really just everything and anything, perhaps some situational questions that might come up often. We were given some examples of that as well, so we can answer any questions that our patient might have regarding this questionnaire. Sorry. Okay. And I know earlier, there's a lot of discussion around building trust, right? So a lot of our patients do have a language barrier who are admitted. And so we heavily, use our voice interpreter services to guide and help with, the answering or explanation of why we're doing this questionnaire. So just to give you some background, if you've never heard of voice. So voice connects our patients to a live, medically trained interpreter in over 240 languages in literally under a minute. So this comes in a tablet form, so we have some iPads on a unit, but also every patient's bedside has a integrated bedside terminal with this app on it. So if we're going at the bedside and asking the patient if they'd like to complete this questionnaire, we're utilizing the voice app to help explain and provide any translation as needed. And Ontario Health also provided us this questionnaire in 16 different languages for perhaps those individuals who prefer to complete the questionnaire independently with family member, and we will just pick it up the next day, or there's instructions on the questionnaire to hand deliver it to the clerk upstairs or the reception. This is a snapshot of what it actually looks like in our medical in our EMR called Meditech Expanse. So as you can see, we built all the 13 questions, and to make it quick and easy to fill in. So when we're at the bedside, it's just a paper copy questionnaire, but then it's given to staff, so patient relations and experienced staff, to transcribe it into the EMR. And so you can see these are the 13 questions, and at the top it'll say, do you agree to answer the questions? And so it will prompt us in the work list if we haven't filled out this area. So given the sensitivity of this, of this questionnaire and a lot of the questions that are presented, we know and recognize that there are several, critical data privacy considerations that must be addressed. So the first one is consent, so transparency. I know we've talked about that, a lot yesterday and today. And so patients or family members must understand how their data will be used, stored, and shared, especially when it's being used for research or aggregating to larger data sets. And understanding that this whole questionnaire is voluntary. So when a patient is asking us, well, do we have to answer it? Well, you don't have to answer it, but we do encourage and we provide them with an explanation on how perhaps filling out this questionnaire will help to contribute to health equity goals and inform our program planning and delivery. Next is obviously patient confidentiality. So, health data does comply with PHIPAA, as well as we ensure that their information remains confidential. And just going back to that EMR screen, so that section of the EMR is currently not visible or not visible to our healthcare providers, our clinicians, frontline staff. It's only visible to those who have access to the health equity profile, which is just the patient relations and experience team currently. De-identification and anonymization. So when collecting the data for analysis, we de-identify and anonymize the patient data to protect their identities. So like I said, when we do our reports and we submit them to Ontario Health, it's really just a summary, high-level collated data, and so individual, patient data is not being shared. And lastly, obviously, security risk. So we noted that, cybersecurity, so with the increasing use of digital technology and EMRs, there are heightened risks of, data breaches, hacking, ransomware attacks. And so the hospital does have a security operations center that prevents and mitigates any cyber attacks. And along with the data privacy considerations, there are also some potential biases in data sources that we want to address as well. And Shakil touched upon that earlier. So non-representative data. So like I said, this survey is voluntary. So really, we may have a lack of representation from marginalized or underserved groups. And we may have, lack of data or not capturing the experiences of those individuals who do not have access or choose not to access healthcare services. There's also reporting bias. So as we're analyzing our data, we must consider the reporting bias and provider bias. So reporting bias, so there may be under-reporting in certain populations. So in marginalized or vulnerable populations, some patients may under-report issues due to fear of discrimination or mistreatment by healthcare providers. And sometimes, we noted that patients may feel pressure to provide any answers that they believe are acceptable or expected by us healthcare providers. And of course, provider bias. So sometimes we may, or us or staff may unintentionally influence how patients respond to the questions, either through the framing of the question or through their own biases. And now I'm going to pass it along to Shakil to talk more about the use and application of the equity data in hospitals, but more specifically at Runnymede.
Thank you. Having this means I don't trust technology. You talked about trust. One time I got the job because I had the PowerPoint. the technology was not working. I had the PowerPoint. They said, "Oh, this guy plans." So again, Ontario Health has given us this experience of how hospitals on Toronto are using this data. And I'll quickly go there because I have 9 minutes and I want to give some time for you to ask questions as well. Is that some of them are looking at cancer screening and how inequity is affecting that. We are starting to look at FIM. Simply put, it is about mobility of the patient at the time of admission and discharge. And so those are the things that we are planning to do. I don't want to go into the details. The slides are already there. Some hospitals are looking at access by new immigrants. They are also vulnerable population. And I'm very proud of Voice. I'm not their sales representative, but it's a real-time translation of the patient ability to converse with us, and it really helps. So this all PowerPoint is you can download, but we realize that this is a data summit. So we have a lot of data, but we chose some of the data to share with you. So in our Runnymede, 40.5% identified as a person with a disability, the patient population, and 37.9% identified benefit from support related to physical disability. So you see where the story is going now, and then indigenous was 1.6%, and the Afro-Canadian, Afro-Caribbean, it was 7.1%. So these are some of the data. Data for me is not the end goal. Data is for me something saying, look at it, try to understand it, and see what is the actionable items. So one actionable item was, in terms of So we drafted an equity charter, and again, this is Ontario Health Toronto Group work. And then we did sensitivity training for leadership. 6 Health Excellence Canada has those. We did it because, first we need to understand before being understood, right? So we want to understand what is this culture and sensitivity training. So we did on Indigenous history, we did on implicit bias, we learned about coin of operation. That means if I am of certain ethnic race, so I am facing inequity there. But if I'm rich, there I'm actually on top in that. So you see the equity is not one way of looking at it. And again, because, our population seems to be talking more about physical disability and disability, our accessibility plan had to be made more robust. That's what the data is telling us. And again, do not forget PFAC. PFAC represents our patients, so they are very much involved in this decision-making process. So I always say, as healthcare provider, we should not think of what patient needs and design it, including data people. We heard, patients being involved in this, and that's our message also. So, the Indigenous. We had Strawberry Moon Festival. We invited an Indigenous elder, and it's an opportunity to learn and understand and be closer to nature. And in the strawberry season, when they are harvested, and the Indigenous elder told us something else. Hey, by the way, do you know if you refuse a smudging process to an Indigenous person in your hospital, and I mean indoor, not outdoor, go outside and do it, no, indoor, then you are open to financial penalty. It's an act in Ontario. I didn't know about it. So we quickly start in our no smoking, making an exception and involve facility to this. So that's how we learn from them. And again, kudos to Ontario Health, because they said in their, your organization equity implementation strategy, you should be reaching out to advocacy groups of diverse ethnicity and learn from them. So we are learning. So, in terms of, I will go fast, understand your population and design accordingly. I already talked about, for us, because we are a rehab hospital and a medically complex hospital, the functional independence measure is quite important for us. Well, we are told that we are one of the better ones in the Ontario based on the reports that we get. However, have we looked at it from equity lens? So that's something we are thinking. We need to look at it is that the vulnerable population, do they tend to have a lower functional independence measure, though when they're starting, they're at the same level. We are going to look at our incidents and how the inequity is affecting that. We already talked about language and how we are trying to address it. People here talked about accessing primary care and allied health care. That is always an Achilles heel, that when you are discharging, how do they access? And is there inequity in access? And we are also exploring about printing wristbands with updated pronouns. But we are very, very cautious. So implicit bias, right? So when we were meeting with the hospitals who are working together on this, all hospitals said we do not want to share individual patient data with individual healthcare provider. Now you may disagree, but they were scared that there is implicit bias, and we have heard stories of how the care got changed once this information reached the individual healthcare provider. So currently the plan is, as Kim said, collated data, what it means, what we can improve before we have the education and the awareness, and then when we are ready, then we start sharing individual data. Now we are hoping for feedback from you all so that we learn and we modify our our strategy in this. Again, hiring of more diverse staff and peers, and we are looking. No, we are a part of a small part of Ontario Health equity strategy. So microsystem speaking and saying, oh, this is what we need to do in Ontario Health, and And bottom line is how we can use this information for clinical care outcomes. If you look at literature in USA, they're working on Afro-American population and their hypertension and how equity data is affecting. So our ultimate goal is how this will impact that. So she talked about evaluation. We are not in the evaluation phase, but that doesn't mean we don't continuously evaluate our own process, what we are doing, and we are opening this to you also to evaluate this. And then we have been quarterly reporting to Ontario Health on our processes. And the last thing is this is their framework, and we are saying how we can align more with their framework. And we heard about ethical framework, regulatory framework. This is the equity framework that they are proposing, and our work is that we will align our approach to this. Thank you. 1 minute for questions. Thank you. Any questions or suggestions? I always love suggestions. No difficult one, please. She will answer all.
Hi, I'm Amira. Thank you so much for this presentation. I really appreciate how it covers everything from language to even the medium in which the questionnaire is being delivered to the patient. I also really appreciate that your strategy includes the cultural sensitivity training. Just a comment here, like cultural sensitivity can be a self-established barrier for some patients to actually go out and seek the care that they need. Would you be able to share with us what that training curriculum includes or how that is translating to individualized care on the front lines? Thank you.
Shakil can answer that question.
So again, this is the start of our journey. So, in our discussion with Ontario Health, we were saying, you need to give us some training modules and all those things. So, but we seeked out Health Excellence Canada, you go there, and there are equity trainings. This is the basic start, right? Is it related to clinical outcomes? Not yet. Yeah, but we are a part of that Ontario Health training group. So we get in wherever we want to. Is how it can be more outcome related to clinical outcomes. Meantime, it doesn't stop us from reading literature and trying to understand clinical outcomes and equity. But very good question.
And just to add on that, I know that we're part of the Northwestern Toronto Ontario Health Team, so they're currently seeking individuals to be part of a working group to look at the cultural sensitivity training better and what we can provide other hospitals to help them throughout this process. Okay.
Maureen, I'm looking for suggestions, huh?
I was just wondering, you talked about compliance and people, it's voluntary. So what's your response rate like right now in terms of people actually providing the information, and how well are you doing on that front?
So currently, our decline to participate is around, I think it's 51%.
And does it vary by is it just all 51, or is different questions more likely to be?
Yeah, so the next step is to really so overall, so if we're looking at all patients that were admitted, around 51% has declined to participate. However, the next step in the evaluation is to look at the breakdown for each question. So under each of those 13 questions that you see, aside from all of the checkbox selection, every question has either a prefer not to answer checkbox or like a do not know type of checkbox. So we want to review each of the questions, especially, we understand that some questions may be more sensitive than others. So we want to know, okay, if there's an area or question that has, like, for example, 70% of prefer not to answer, we want to be able to address that and look at how we can encourage patients to answer that question, but also share this feedback with Ontario Health. And so recently, since this whole rollout, we just submitted like our first summary report to Ontario Health Analytics team back in September. And so we're waiting to hear back from them, as well as like looking at what other peer organizations, how they're doing, and perhaps learn from each other as well, because perhaps they're going through the same thing and having these challenges.
Thank you for
Thank
listening.
you.